Good morning. How you doing, Dave? Herms?
Hey, good morning. Good morning.
David, how are you?
Doing great.
We've been listening. What a great panel. We've been listening to you guys, and it sounds like that was just a tremendous show that they put on from Duke. So we're very appreciative and really love the comments. I'm going to do something. We're going to introduce the case. I don't want to take more than 2 minutes to introduce the case, but we'll come back because this case just got added on late. But Alok in the next room is going to be doing a Watchman, but we'll come back for this case. So let's get right into the presentation. Here in the room we have Madi, we have Kendall, and we have Steve. Nick Bellner is passing anesthesia for us. Just we didn't want to have to think about that. And we have some of our support friends from Boston Scientific in the room too. Okay, get to the video. Okay. This is IVUS-guided PCI of the LED and circ was done in 2001. The guy presented with chest pain. He's 72 years old, chest pain and dyspnea, and the stress test shows inferior ischemia. So you'll be proud. This is my diagnostic.
Beautiful technique.
Beautiful technique. You like that?
Yeah.
So go to the next picture. So this is what we're doing, dealing with. You can see stents in the LED and the circ, and there were stents placed in the right. They're all bare metal stents. And actually, the stents, we did IVUS-guided PCI, back in 2002 or something on this guy, and the LED and circ stents are wide open, and it's going to be that stent of the right coronary artery. Go to the next picture. Or not. Can you pull that back up, guys? Any observations on my radio? Oh, that's good. The computer just died?
The computer died. That's great.
Any comments on our technique for my passing that woolly wire up there? Anybody have any observations?
Yeah, I'm just curious about Baby J versus. I get a little nervous with Wallies, to be honest with you. Guys, what do you think? You do more? I do about 70% radials. You guys do more? Do you use Wallies or Baby J's or not?
So I've used Baby J, again, as a trainee of Sunil 5 or 6 years ago. Baby J is really nice, especially for not getting into, for example, going up the left and getting into the Lima. Like that actually happened to me when I was an attendant, first year attending, and a fellow actually put a regular 035 guide wire into the Lima and dissected it. And so Baby J is really nice because I really think it protects you all the way up. A woolly wire is good too, though. I think the cost of the Baby J is significantly more.
Go to a straight AP. All right, go to a straight AP view, please. The computer died that they're presenting on, so, but here is in the straight AP view. Go off mag, please. Take it down a couple of mags. There's a restenosis. Anybody want to make any observations about the cardiac silhouette?
It looks like it's on the wrong side.
Yes.
Thank you.
There we go.
Someone got it. So here is the cardiac silhouette. Now, in this, when you see it in this view, on the left side of the screen is the LED and circ and the stents in that, and to the right side of the screen is the right coronary artery. So to lay out this right, okay, go forward on your pictures. To lay out this right, we're doing a far angulated, the opposite of what we would do, a far angulated RAO. Go next. So this gentleman has dextrocardia, he's got 2 children, and he doesn't have any chronic pulmonary infections. So what we have here is a heavily calcified mid-right. Proximal to the stent, there's a lesion, and then that heavily calcified. Now, I got to tell you, I was thinking about all my CTO technique and this and that, and I know I'm standing in the midst of interventional greatness, but this guy next to me, go forward, does it with a Pro Water. And he got the Pro Water way out there with no aid. We set up a base of operation with a Corsair catheter. He got the Pro Water through, and then we pushed the wire all the way out the Pro Water and then replaced it for a rotofloppy. Because our computer died, and I want you to see the other images. Okay, we're going to go over. Any comments real fast, David or anybody else?
So, David, here is Manish. A terrific, complex case. You got a pro with you in Herms, but I think that this is going to be an outstanding demonstration case of how you get through those stents treat not only the prox, but also the heavily calcified mid. And we look forward to looking at this as you get started.
So do you see my presentation, my PowerPoint up?
No, we don't see that.
Well,
Put
we
the
see
PowerPoint
an angiogram, yes.
Okay, take the angiogram down, put the PowerPoint up, please. Tell me when you see my PowerPoint, guys. Okay, go forward.
Not seeing it yet.
You just see the left coronary circulation or no, guys?
Yeah.
Yes, yes,
Okay,
we do.
there we go.
We do.
So there's my stents in the LED and the circ. They're wide open. And the interesting thing about doing transradial, this is the second transradial dextrocardia I've done. Just use the same catheters.
Yeah, yeah.
They fit beautifully. Go next.
Just bass backwards, right?
Just pass
Yes.
backwards. Next. Next. And
There
here's
we
the
go.
right coronary. So this is what we were dealing with. It's a fascinating case, and the gentleman, the patient said, oh my God, every time medical students come in the room or residents, there's a line of 10 people that want to listen to him and hear the heart sounds and everything. So he was just very willing to have us do this as a live case. So why don't you and I go to work?
Yeah.
And let's send
do it.
over to a LAAO, okay?
Okay, perfect. All right, we've made some real progress here. This is actually terrific. We decided to be ready for anything on this case, so we went femoral with an 8-French sheath. You can see all the tortuosity down here. We got a long sheath up into the thoracic aorta. Next. And then next. And then dextrocardia, we had a little trouble with the AL1, and so we went to an AL75 and got in. And if you want to just show the cine. And that's what we had, right? And just love to hear what people would say, how they'd approach this before you show you what we did.
Rob, you're at the end of the table. I'll sort of let you speak here. I'm really curious about what your approach to this would be.
Yeah, I mean, you're clearly going to need something, right? This is not going to balloon expand. You have heavy calcification distally. You can see that it's on both sides. Given lack of a balloon that might emit something to help us out through this case, let's say that's not available, you're clearly going to have to do something. So we saw a rotoburr earlier in a few images. I don't know if that was some foreshadowing or not, but when we think about taking a burr through this, obviously there's a big stent there, and so you're going to have to be really careful. There's some angles there, and so the art of rotational atherectomy is up if we're going to do that. It is not as simple just putting the burr down. There is a very significant art of feeling that through stent struts and listening and feeling and looking at your RPMs and letting the burr and your pressure take you through that area to get yourself distally. And then it's not just, you're not done there. You have the really fun aspect of bringing it back again, which is going to require a lot of precision and certainly not your first rota case.
Yeah, that's really a very good point. We had a Guidezilla, Boston Scientific Guidezilla, it's sort of in the background in case we needed it. We didn't. Herms, I thought what was interesting about this case, go forward, and go forward again. We rotoglided, dynaglided the burr, go to the next picture, past that first lesion.
Yeah, and with the dynaglide, it just slipped in. I didn't have to put any pressure on it at all. It just went right around.
So look at what we're doing here. Now, it wasn't going past that area. We got severely bradycardic, dropped a pacemaker in. Might have thought about putting a pacemaker in beforehand, but we dropped a pacemaker in. No problem, no urgency. But and then go to the next picture. We couldn't get it. There was a lot of tension in the cath. There's our pacemaker. Next, and this is the first time I've put a pacemaker in a dextrocardia, and I kind of was.
Next.
And so, go forward now to the next picture. So now we rotoed again, and Herms was just pecking away, and then it gave, and then it went around there. And then it looked on the next picture. Go next.
Dave, that's a 1.5?
That was a 1.5.
Yeah,
It was a 1.5.
I wouldn't use a 1.25. I've almost abandoned. I'd be interested what people on the panel say. I've abandoned using anything but one. The smallest I use is a 1.5.
A 1.25 through stents it gives me visceral issues.
Exactly.
Shudders.
Yeah, that back end of that, it's like a bullet.
Right. So now it looks like a grenade blew up in there.
We got a trench.
So go next. And then with great ease, a 2.5 NC, then a 3.5 NC. Go forward. Go forward. That's where we're after the 2.5. There's the 3.5. Go forward. Go forward. And then watch this. Next picture, go forward. And with its incredible delivery profile, watch this synergy with no guide liner and just an AL75. Watch the synergy go out there. I mean, this is just such an incredibly deliverable stent. I know that's not a cliche. Look at it, it wasn't that hard. Herms put a little back tension on the wire, and around that bend she goes. Go to the next picture.
We did switch out for a wiggle wire
Yep.
after we had the roto wire out.
And there's our 4028 synergy. Go forward.
So that little distal thing you decided not to
You know,
treat,
I
right?
think it's going to be a wire.
Spasm?
Yeah, wire kind of straightening down there.
Go next. And this is where we're at. Oh, I didn't take a picture. Next. Oh,
Okay.
Here, let's take a picture. Hang on. And go. So that's where we're at right
See
now.
that, Dave?
Yeah,
It's
yeah,
bad.
yeah. Well, President of Shea has to notice things like that.
Yeah. So I think the next thing for us to do is we'll post-dilate this stent, and then we have to address really that lesion, which is a proximal focal border stent
Yeah.
restenosis.
We'll just put
We'll
We'll put a little shorty up there after
yeah.
we dilate. I think we need to oppose this stent. We don't need to go crazy with high pressure. I think
We'll probably ultrasound this now just to make sure that we have full apposition. I think this is one of the real beauties of ultrasound. And now he's starting to take over his own intrinsic rhythm more and more. So I think we're in pretty good shape. And we have some more work to do. But this was a great case and a fun case. It's always fun scrubbing
we had a
next to
great
you.
time.
And I'm still amazed he wired this with a workhorse wire.
Yeah, no, it was beautiful result.
Fantastic. I think a lot of teaching here. The only question I had, Herms and David's, so, plaque modification, 1.5 was sufficient. You got it expanded. Any reason to step up the burr, and when would you do that, Herms?
Yeah, so great question. We were a little hesitant with the 1.75 because he hated the 1.5. I mean, we had some screens of nothing on it initially, and two, it looked like we had a pretty big trench already because of the angles that we had. So we went in low pressure. This thing released at 4 or 5 atmospheres. We didn't just stop at the 2.5 balloon. This is a very important teaching point. We went to a 3.5 to absolutely be sure this thing would dilate, and the balloon came up at 4 or 5 atmospheres.
And we went in with a 3.5 NC. I think that's another good, important teaching tool.
If that NC didn't look perfect, we would have thought about stepping up on the burr. But I think we'll optimize this with imaging and so forth and so on. But given everything, I didn't see a good reason we need to go with a bigger burr.
So is orbital safer on bends like this? I don't do orbital, so teach me. I'm a roto guy.
My take is no. I actually, I think this is a great place for this device.
I think orbital, you're not going to take this through the proximal stent like we did here with Rotoglide, and I think that's really where the advantage is. If you were going to do orbital here, as Dave and Herms had set up with a Guidezilla, have the Guidezilla around the stent and then bring your orbital through that. You're not going to drag an orbital through.
Yeah, the leading edge of the orbital through that. Look at the angle of where the guide and that bend and where that stent is. That leading edge of the orbital may give you significant consternation as opposed to a rotoburr that if you get stuck there, you're just going to turn it on and use the rotational atherectomy aspect to actually navigate that corner. I think what they were talking about earlier, the 1.5 versus the increased size burr is huge here. You're just looking to frack that calcium. You're just looking to break up the plane so that then what they did, the unbelievable pre-dilation and vessel preparation, that's one of the most important things of this case. So using that to frack, prepping it correctly, and then being able to get that stent in. So it was very amazingly fantastic vessel preparation that allowed that stent to get through there. So great job.
Yeah, and I don't think you can overemphasize the fact that after you run through with this burr, you have to make sure this vessel can be dilated. I see it too often that 1.5 burr and maybe a 2.5 balloon and a 4.0 vessel, and now you've got stent regret because you can't dilate the stent. You didn't really check.
We're going to turn it back over to you guys. We're going to work here a little bit more. Maybe we'll come back when we're, finished. But we're going to go in with a larger balloon, NC balloon, hit that distal stent, show that a little love, and then get the proximal, IVUS it, and then maybe we'll come back. We'll see. Okay?
All right, guys. Great.
Fantastic.
Okay, we put a stent in the prox. We put a 4.0 synergy in the prox, and now we're just post-dilating at high pressures, and we're going to give you one picture here.
Let me just do it one more time,
Yeah.
since I went to vote.
And you know, it really, the stents all went, I just can't say enough done. The stents all went in very easily. I think one of the beauties of delivering the synergies in vessels like this is that it's a highly deliverable stent. I think
Oh, that looks better. Yeah, great.
Beautiful.
so. We did a 4.5 NC in the mid, full expansion, easily fully expanded. Dropped a 4.0 stent in that very proximal border stenotic area. Post-dilled with a 4.0. We're going to IVUS this and decide if we go in with if we need to go bigger.
Yeah, and for Dave, that little spot with spasm distal to the
Yeah.
mid-stent looks great.
Looks fantastic.
Yeah.
All right, we're good. We're going to just wrap up here, do a little more touch-up work, show this vessel a little bit more love, and then we'll be over there.
Nice job, guys.
Fantastic. Great job.
Great.